outside with a blister, and she was completely unaware of what was, the pain, because she had insensate feet. Here is a patient with advanced neuropathy affecting both the hands, the wasting of small muscles of the hands, the wasting of the small muscles of the foot, altering the posture, if you like. There is tendons pulling on these bones and flexor tendons pulling, but there's no opposing muscle to keep the foot straight, and you get the clawing of the foot, which renders the foot then vulnerable to neuropathic foot ulceration in these prominent metatarsals. And a lady who kept burning her hands when she was ironing or using the oven. And he's a patient who walked with a nail stuck through her foot all day and without knowing. And luckily, somebody like Howard looked at her and actually took this, and the symmetry was preserved, and she did very well with surgery. So unfortunately, many of these patients with infection and Charcot that you can see end up having amputations. And we have a large chunk of patients also that have autonomic neuropathy accompanying peripheral neuropathy or distal symmetrical polyneuropathy. Here's a lady with gastroparesis, gustatory sweating, and we have also patients who suffer with severe painful diabetic peripheral neuropathy. So really the focus is going to be on these peripheral neuropathies rather than the focal neuropathies. So diabetic peripheral neuropathy or distal symmetrical polyneuropathy, it's symmetric, it's length dependent, affects the longest nerves, it starts in the toes and gradually marches upwards. And once the disease is well established in the lower limbs, the upper limbs are affected. The nerve length from the lumbar region to the toes is longer than from the cervical region to the fingers, and it affects the longest nerve. So it has to be well established in the legs before the hands are affected. And around a quarter of all people with diabetes, or half of the patients with peripheral neuropathy, develop neuropathic pain. And diabetic neuropathy is very, very common. It affects 1 in 2 people with diabetes. So how do we diagnose this condition? We take history from the patient. They may have absolutely no symptoms and present with a foot ulcer. Or they may have some symptoms, the positive symptoms so-called, persistent burning or dull pain in the periphery, in the feet, starting with the toes, or you can get paroxysmal, occasional, electric shock, stubbing, knife-like pains. These are, ouch, they wake up with this shock of a pain. Dysesthesias, these are painful paresthesias or tingling or pins and needles. There are various descriptions of these neuropathic symptoms. Some patients can have evoked pain, a non-painful stimulus perceived by the patient as being painful, allodynia, and a painful, slightly painful sensation perceived by the patient as extremely painful, hyperalgesia. And some patients may have so-called negative symptoms, and they can have a feeling of numbness or dead feeling. And this could be uncomfortable, as if your tooth is frozen with Novocaine, and that uncomfortable feeling of numbness. And they can present with hyperalgesia, inability to feel pain, and analgesia, complete inability to feel pain. Hypoesthesia, inability to feel, and anesthesia, complete inability to feel. So various symptoms. And we can readily make the diagnosis using simple bedside instruments such as the tuning fork, the 1-2-8 tuning fork applied in the toes, or we can also use the patella hammer. Those reflexes are lost particularly in the ankle rather than in the knee initially. And also pinprick sensation, and you can also assess temperature sensation in the feet using a cold fork. And simple bedside instruments, within 5 minutes you can diagnose peripheral neuropathy. Now, the UK was really the first country to achieve this important milestone, and that is that diabetes is no longer the leading cause of blindness in working age adults with diabetes. Now, previously, it was considered that diabetes was the leading cause of blindness, but because of screening, this is no longer the commonest cause of blindness in working age adults. And this has been a great success, and because the government indicated that all diabetic people should have eye screening done about 15 years ago. So annually, everybody has to undergo dilated pupils, retinal screening, using retinal photography, and at the earliest changes, patients are referred to see an ophthalmologist, and this has been a game changer. Unfortunately, and the same cannot be said about the diabetic foot. Unfortunately, in the UK, we have around 140 now. That's the latest figure from Diabetes UK. Amputations every week, and these are paradoxically actually rising. The figure's rising. Okay, the diabetes prevalence is also rising, but you'd think that over the years we would be containing this, but we're not. And Diabetes UK called on the government and the NHS to act urgently with a huge campaign over the past 5 years. Now, when we look at the financial cost of ulceration and amputation, this is truly staggering. The NHS cost is around 1 billion, and this was in 2015. And 1 in every £140 NHS spends is on the diabetic foot or the management of the complications of the diabetic foot. And what is staggering when we put this in context is that actually the cost of the diabetic foot was higher than the combined annual cost of 3 of the most common cancers. And yet the cancer charities raise so much money, they get a young boy or girl with leukemia, and there's huge research in cancer research. Diabetic foot is truly the Cinderella. Not much research is being done in the area. In fact, the awareness is lacking. And when we look at the amputations, they are devastating. They're devastating physically, as you cannot exercise and function normally, but also mentally. They are devastating emotionally. And you can see the EQ5D quality of life for patients who undergo major amputation is the worst compared to hemodialysis and all the other complications that you can see. Even patients with diabetic foot ulceration, they spend half their life in clinics, coming in and out of hospital, and it's not truly a good way to live. Now, why is this? Why are we having this tide of amputations in the UK? And the reason is because we're diagnosing the condition far too late. We're using these implements, the 10-gram monofilament, which is a brilliant, simple test to diagnose a foot ulcer risk, but it is not a good way of diagnosing neuropathy early, because it diagnoses neuropathy once it's reached the knee that you can see it's almost too advanced, is completely irreversible. Here is one of my patients. I was told my feet were fine on the annual check until last year, when I was told I have nerve damage. Now I'm attending the foot clinic. Unfortunately, as soon as they attend the foot clinic, their risk of mortality is massive. You can see the 5-year risk of mortality is 50%. And you can see, you can compare it to only lung cancer it's above colon cancer, above many cancers, the actual risk of death, and particularly if you have ischemic ulcer. And the 2 diseases that have worse outcomes are lung cancer and pancreatic cancer. Painful neuropathy is also common. It affects 1 in 5 diabetic people. This was a study done in the northwest of England, massive study, 15,000 people in the community screened for the neuropathy by podiatrists, and they found that actually 1 in 5, 21%, had painful diabetic neuropathy. But what subsequent studies have shown is that actually around 40% never receive any treatment for their pain. They do not associate the pain that they get with diabetes. Many of these patients think it's part of a normal aging process, And it's up to us really to inform them, to ask if they have neuropathic pain, to diagnose it and start managing these patients, because most of these patients require treatment. I run one of the biggest painful neuropathy clinics in the country. And indeed, most of our patients actually come from outside Sheffield, in the UK, and indeed internationally also. People come because we have a neuropathy lab in Sheffield. And you can see these patients presenting with burning pain, with electric shock type pain, ants crawling in their feet, ice, various neuropathic symptoms leading to psychological mood disorders, anxiety, depression, anger, etc. And this has eventually social consequences, marital disharmony, social isolation. The patients don't function normally. They tend to isolate themselves. They don't even go to social gatherings, and they have a really poor quality of life. But unlike other chronic pain conditions, such as chronic back pain, many of these patients have obesity, nephropathy due to the diabetes, unsteadiness and falls because of sensory ataxia, postural hypotension due to autonomic neuropathy, peripheral vascular disease, ischemic heart disease. Strokes are far more common in diabetes, foot ulcers, visual loss, and each of these can have psychological, if you take visual loss, and social consequence by itself. So we deal with very complex patients, and I see many of these patients in our foot clinics. They have what I call the full house. They are on dialysis, they have all sorts of problems. And that's because we're missing the boat. We're not diagnosing the condition early. We're missing the early signs of disorder. Now, if actually you do skin biopsy, and I want to show you I don't have a pointer, but I can point you to the middle of the slide where you see these little spaghettis that you can see, little nerves on the epidermis. These are called intraepidermal nerve fibers in the skin of the foot. You do it by skin biopsy. We do it all the time here in Sheffield. And if you send that, and you can see already the IENFD, or intraepidermal nerve fiber density, is reduced in patients recently diagnosed with type 2 diabetes. So already the disease is there, but because we use this monofilament, outdated stuff, we miss these signs. We give them a false sense of security when we see them in primary care. We say, you're fine. They're not fine. The disease is progressing. If you use serial sensory conduction velocity and amplitude, you can see, in fact, the disease is already there. And studies also show that even in prediabetes, and this is impaired fasting glucose or impaired glucose tolerance, these are patients that haven't hit the threshold of diabetes, have higher prevalence of neuropathy sometimes, particularly in patients that have vascular burden. This was done in the Monaco Cora cohort in Germany. These were elderly patients by and large and had high vascular risk. And you can see the neuropathy prevalence was higher than even in newly diagnosed diabetes. So the reason for these is that neuropathy is not just driven by glucose. This was a study we did many years ago, because I noticed many patients coming to clinic had absolutely no neuropathy despite having excellent blood glucose, or despite having very poor blood glucose, or vice versa. People that had poor glucose control didn't have neuropathy. And I was wondering, is the glucose the main driver of the condition? And so we did this massive study. We studied 3,250 patients across 16 European countries, 31 centers. And we excluded the patients that had neuropathy at baseline. We followed 1,100 patients with no neuropathy for 7 years. And what we found was that the incident or new onset neuropathy was driven by hypertension, smoking, glucose control, the change in glucose control over the 7-year period, increased diabetes duration. As duration increases, neuropathy, everything gets worse. Obesity, triglycerides, and cholesterol, these were drivers of neuropathy. So neuropathy is not a sugar disease, it's a vascular disease. And the management of neuropathy should be should be based on, or should be aimed at, the comprehensive management of cardiovascular risk factors as well as blood glucose control. So how should patients be diagnosed for neuropathy? The American Diabetes Association came up with this really interesting new look at an old problem. Start screening for neuropathy in any patient with type 2 diabetes from diagnosis, and 5 years after the diagnosis of type 1 diabetes, and annually thereafter. We should consider screening patients with pre-diabetes who have symptoms of neuropathy. Assessment should include comprehensive history, temperature or pinprick sensation to assess small fiber function, vibration sensation using the 1 to 8 Hz tuning fork to assess large fiber function. We should do the monofilament test to assess foot ulcer risk also. When we have atypical features, diagnosis unclear, asymmetrical presentation, or any odd features, then these patients can be referred to us who have an interest in the area of painful neuropathy, or can be referred to a neurologist. And their care, they need nerve conduction studies doing. So what consensus panel has been established to look at this? I was chairman of the International Consensus Panel on Diabetic Neuropathy, and in the middle you will see Professor Peter Dick, who's 90 years old, who is my really great mentor from the Mayo Clinic. He still continues to work. He's an amazing man, and he had back-to-back publications in the New England Journal a year ago. And all these leading figures from Harvard, from Michigan, from the UK, Professor Andrew Bolton is right in the front. Then we came up with a consensus on how to diagnose, because people are doing what they fancy around the world, and we need to have a standardized approach. And what we came up is that if patients have symptoms or signs, the diagnosis is only possible. If they have symptoms and signs together, the diagnosis is probable. It's only confirmed, particularly for research purposes, they have to have an abnormal nerve conduction or an abnormal small fiber function using intraepidermal nerve fiber density or quantitative sensory testing. So this is the gold standard, if you like, for confirmed neuropathy you need to do. But this is, at the moment, skin biopsy. We only do it to confirm atypical cases, odd presentations for research purposes. So what have we done in Sheffield? These are my colleagues from Sheffield, the podiatrists, Jeremy Walker, Oliver Binswald, these are podiatrists, Deborah Sanger, they're all my colleagues. We thought, because foot screening wasn't happening in primary care and a lot of patients were presenting with foot ulcers, we said, why don't we have a one-stop shop? And this was published in Diabetic Medicine. You can download it, it's free to download. In fact, all my publications are free to download. If you just Google my name, on the right, you will see all my publications, and you can download all of them. So what do we do? So patients come for eye screening in a hospital setting at Northern General or community GP practices, large practices. So while eye drop is working, it takes 20 minutes. Patients are sitting doing nothing. They can't read. So that's when we attack them. So the podiatrists take shoes and socks off and examine the feet with deformity, etc. They do a comprehensive foot assessment. Also do a sural sensory conduction velocity and amplitude using handheld device. This is only unique to Sheffield, and in America it's widely used. This is a handheld device. In 3 minutes will give you a quantitative figure if somebody has an early neuropathy. We also use Pseudoscan, and these measures sweat function, small fiber function. It is an expensive instrument. You don't have to do it. I think even simple proper clinical examination in the tuning fork, etc., can do. And then we spend 2 minutes, DN4 questionnaire. We use this to assess if the patient has neuropathic pain. It takes just 10 questions. In fact, the patients fill them in before they come to the meeting, to the appointment. We also do blood tests, we do weight, height, we do all 8 care processes for the patient, an MOT if you like. And the patients love it. Patient feedback is amazing. They don't have 3 appointments to see the GP, the podiatrist, everything done for the patient in one go. And now Diabetes UK is a very high priority to put these nationally, but we need to prove that it can be done in London, elsewhere. So I'm just going to put in a grant application, NIHR grant application this coming January, health services application. So what did we find with this one stop? Well, you can see that if you use the monofilament, you diagnose neuropathy in only 14%. If you use a detailed clinical examination in 30%, this is a Toronto clinical scoring system. Pseudoscan 38%, but the DPN check, you diagnose neuropathy in 50%. Many of these patients are walking the streets of Sheffield not knowing they have neuropathy. They're walking the streets of the UK and the world indeed. And we found new diagnosis of painful neuropathy in 25%. And this was really staggering. I never thought that patients would have painful neuropathy and not present. The mean score was 5.3 and the NRS out of 10. And therefore anybody above 4 requires treatment. So this is not fair really on the patients. And you can see combined DPN check and Pseudoscan had 94% sensitivity and 62% specificity to diagnose peripheral neuropathy. Can be done in 10 minutes. So conclusions, amputations are increasing in the UK. Combined eye, foot, renal screening is feasible, has high patient acceptability, reduces clinic visits. The prevalence of DPN is completely underestimated by the 10-gram monofilament. Combined use point of care devices use extremely sensitive, but even clinical examination, you'll diagnose in around 30%. There is high correlation between the point of care devices and the clinical examination. I didn't show you the data. And we found also, as I showed, painful new diagnosis of painful neuropathy in 25%. So, how should we manage these patients that we diagnose? And I'll be talking about how we manage these patients. Those that have neuropathy, 10-gram monofilament that's already positive are offered podiatry service, foot education, orthosis, and those with foot ulcers managed in the MDT foot service. Those with subclinical neuropathy and don't have 10-gram monofilament positive, but they have point of care device abnormality referred to multifactorial risk reduction clinic. The patients with painful neuropathy go to our painful neuropathy service. So before I talk about the management, I just want to talk about the pathophysiology, pathogenesis of diabetic neuropathy. Ladies and gentlemen, many years ago, Professor Ward, who was my mentor here in Sheffield, and unfortunately died last year, and a great man who gave me a great chance and allowed me to be a consultant in Sheffield. I must say I was the first ethnic minority consultant in Sheffield, in working at Sheffield Teaching Hospitals. And he saw great things in me, and I'm ever grateful to Professor John Ward. And so what John Ward asked me is, what does the nerve look like? We can see the eye, we can look at the kidneys by measuring in theatre. Mr. Jakubowski helped me with these studies in Sheffield in theatre. He gave me 1 day a week for 2 years. I'm ever grateful really for his help. And this is me on the left that you can see, and before I developed the metabolic syndrome, as Howard well knows. And so this is all TV that you can see, and what we found was really amazing, and now it's in the textbooks. In fact, we have a paper coming out in Nature Reviews Endocrinology. We've got about 400 references. If you want really the most authoritative review ever done on diabetic neuropathy, I'm sure, I don't mean to be bragging, but you will find it there. It's very long, it's over 12,000, but it has everything on diabetic neuropathy, including what I'm going to show you. So what we found is what we did. We took small biopsy nerve, and the nerve looks on your left. You can see it has the green, these are the axons, the large fibers, the capillaries inside inside the nerve tissue. And then we have the epineurial arteries and veins outside the nerve that you can see. So what we did was first to take a biopsy of the nerve. We took a small piece of biopsy and sent it for analysis in Aberdeen. And what we found was really amazing. You can see in a patient with diabetic control. This was done in 1989. And we found that actually these green nerve fibers are reduced in diabetic patients with neuropathy. You can count them with the fingers of one hand, you can see in A. The circles are the cross-section of these large myelinated fibers. We then looked at the blood vessels within the nerve. These are the capillaries inside the nerve tissue labeled B. And you can see the blood vessels are closed. The circulation is abnormal. Diabetic neuropathy is a vascular disease. It's driven by vascular risk factors, affects the small and large blood vessels of the eye and the kidneys and the nerve. And what we found actually is that there's almost closure of these blood vessels, these capillaries within the nerve tissue, these endoneurial capillaries. And when we look at the outside of the nerve, the epineurial blood vessels, and this was my work with Mr. Jakubowski, really, and you can see the sural nerve in a diabetic control, the artery and vein running parallel along the length of the nerve. There are penetrating arteries that you can see going into the tissue, into the nerve tissue, whereas these penetrating arteries are not there in a patient with neuropathy who has tortuosity and really very poor quality artery, which joins the vein in a direct arteriovenous shunt, upon which the vein then becomes distended and tortuous because venous pressure is high, there is shunting, and the vein is, you can see, tortuous and it has high pressure. It was just an amazing piece of work, and now it's all in the textbooks. To prove that there is shunting, what we did, the reason you have shunting is the blood vessels in B are all closed up. So then the blood takes the route of least resistance and goes from the arterial side to the venous side, bypassing the nerve, as it were. And to prove that, we gave fluorescein angiogram, Mr. Jakubowski, using real-time TV that you saw, the old one. Medical physics helped me with this. And within 30 seconds, the nerve is highly vascular, lights up in a normal diabetic. In a patient with neuropathy, small artery, you can see the big vein because of shunting, but the nerve tissue remains black, as hardly any blood is flowing through it. The nerve is ischemic. So we proved that in established diabetic peripheral neuropathy, the cause is impaired nerve blood flow. But this was not different in those that have pain or painless and painful neuropathy. It's far more complex than these. The reason is pain is perceived in the brain. And I don't have time to develop these. Maybe a further lecture I can give you. We found that the spinal cord is shrunk in diabetic neuropathy, which we published in 1999 in the Lancet. And then more recently with Dinesh Selvaraja, we found there is reduction in the volume of the somatosensory cortex. Peripheral gray matter volume is reduced because of lack of sensation. We found the diffusion using DTI. There are the communication in the brain is abnormal. Resting state functional MRI is abnormal. The perfusion imaging is abnormal in the thalamus, indicating that the circulation of the blood flow. Marnie Gregg has just finished her PhD with me. She's showing really amazing work. She works at the Northern General Hospital. Before her, Rajiv Gandhi, almost all my colleagues were research fellows to me and have built up this picture of involvement of the central nervous system. But unfortunately, I don't have time to develop it. So scenario one, how should we manage those that develop painful neuropathy? And 20 years ago, it was glucose control, lifestyle change, pharmacotherapy with amitriptyline, and gabapentin. We've moved on since then, and in Sheffield we have an MDT approach. We have a doctor, nurse, physiotherapist, pain specialist, psychologist, podiatrist, and so really we have also physical therapists, and particularly those patients that have, the elderly patients require assistive devices, strengthening their muscle, neuromodulation with the pain specialists, complementary therapies, counseling, behavior therapy, psychology, etc. What are the drugs we use? We use pregabalin, gabapentin, tricyclic antidepressants, and diloxetine and SNRI. These are the first-line drugs. When each one of these fails, we combine them with each other, and if pain control is still not optimal, we use opioid agonists as a combination therapy, tramadol, and opiates like OxyContin, morphine, CAM, but we are a little reluctant not to use these drugs. And other drugs are being used. Perhaps in the questions, if you raise them, I can discuss, but I haven't got time really to talk about capsaicin, patch, and other new modern other treatments, electrical spinal cord stimulation for severe neuropathic pain that doesn't respond to pharmacotherapy. Again, that was developed here in Sheffield. We published that in the Lancet. And that is for really severe, intractable, painful neuropathy. We can use it, and the NICE has approved of it, and it is free on the NHS. So, but the problem is we don't know which is the best monotherapy. We don't know which combination is the best. Drug companies don't like to compare their drug against another drug for obvious reasons. And so the government funded me to do this major study called the Option DM trial, which is completed. Results will be available on Wednesday. Unfortunately, I can't share the results with you, but we will know which is the best drug, if there is any, and we will know which combination is the best and which drug has the least side effects, etc., amongst diloxetine, pregabalin, and amitriptyline. If they are all the same, then we could make a lot of savings, because amitriptyline costs 60p, pregabalin costs a lot of money, about 20, 30 times more. If the one is superior, then so whichever way, it's going to tell us some important information. What about the patients that have subclinical neuropathy before monofilament positive? What we should do is improve their glucose control, their blood pressure control, their exercise programs, psychological care if needed, weight loss, dietitian loss. These have an impact on improving neuropathy outcomes down the line. We need to diagnose these patients early in primary care and manage them before they develop advanced neuropathy and come to our foot clinics. What about drugs to reverse neuropathy? Do we have? We don't. Unfortunately, I've taken in around 30 clinical trials over the last 30 years. We try them. They are brilliant in animal models, but in human diabetic neuropathy, none of them have worked. And these drugs are marketed in Japan, in Korea, and China, go all over the world, and they're giving all these drugs. Actually, there isn't any evidence for any of these drugs in disease modification. What about the established foot? This is a lady who unfortunately presented, she was on renal dialysis, presented to us. Unfortunately, you can imagine she was wearing these shoes. Ladies and gentlemen, these shoes should not be made for human feet. Maybe for ostriches or something, but it's good for Italian economy, but not for the neuropathic foot. But the lady refused to wear. She said, "I want to look good," and it's a battle. Unfortunately, she has since died. What about the patients that have, depending on the level of abnormality, deformity, etc., we have an MDT approach, and Howard is one of our really great partners, collaborators, and his team, orthopedic surgeons, Chris Blandell, others, are really amazingly helpful to us. Vascular surgeons, I don't have time, microbiology, orthotists, our podiatrists are the center, really the most important people. So ladies and gentlemen, to finish, diabetes leads to diabetic neuropathy. Motor changes with abnormal posture, sensory damage, reduced pain, proprioception, autonomic damage, less sweating. Increased foot pressure leads to callus formation. Callus formation, patients also have microvascular disease, smoking, hypertension, dyslipidemia lead to ischemia, peripheral vascular disease that lead to foot ulceration. There is a connection, it gets amplified when you have both neuropathy and ischemia. We shouldn't forget limited joint mobility in the diabetic foot. Orthopaedic problems, Charcot-neuropathy, abnormal foot posture lead to foot ulceration. And we can intervene at any point. We can stop the progression, the development of diabetes by prevention programs. We can tackle smoking, hypertension, dyslipidemia at primary care level. When they have developed neuropathy, we can give them advice not to develop foot ulcers, not to increase, or we can tackle early neuropathy, we can tackle with medication, improving glucose control, etc. When they have peripheral vascular disease, we can revascularize. Orthopedic problems can be, reducing the pressure points, can reduce foot ulcer risk. Footwear, etc., all have an impact. Even when they have developed a foot ulcer, we can tackle with revascularization, treatment of infection. So it's never too late to treat these patients. I want to finish with George Bernard Shaw, a great Irish playwright. I marvel that society would pay a surgeon a large sum of money to remove a person's leg, but nothing to save it. I think really we need, our surgeons, our colleagues are brilliant, but I think what we need to do is really invest in having better services for diabetic patients, early detection and prevention of complications. And I've shown you that, and I think I've managed to, hopefully, within time, that seems so ready for questions. Thank you very much indeed.
Thank you, Solomon, for a fascinating and very comprehensive talk. I certainly learned a lot about the complexity of our patients. It was really good, thank you. So like I said, we've got time for a few questions. So I'll just read some of those out if that's okay. So a question from Pauline Cole. As physiotherapists and non-diabetic specialists, what can we do to aid earlier diagnosis? I guess, how can the wider MDT help you and our other colleagues get an earlier diagnosis?
Early diagnosis. I think just talking to the patient, if you sense that the sensation is not normal, and you can refer patients. I've had patients referred by physiotherapists, by podiatrists to our services. If patients are not having appropriate sensation, or their walking ability is abnormal, their posture is abnormal, it can be very helpful. I think it'd be too much to ask for you to make the diagnosis by examining them, but you can point them in the right direction to the general practice, to the fact that to other services. Just having that awareness and discussing. If they have painful neuropathy, you can refer them to our service. Thank you.
Question from Jill Halstead. Do you think we should move to a 1 gram monofilament clinical test in younger people? I guess the idea being it's potentially more sensitive. Is that effective, do you think?
Yeah, I think that's a very good idea. And then people in the Mayo Clinic have done some work showing this. It can go to more sensitive. The problem with the monofilament testing, it's very much a psychophysical test. It's you need the patient's cognitive function to be okay. What we want to do is actually more objective tests, something that you can measure using nerve conduction, something that the patient doesn't have to tell you. They can feel or they can't feel. But the 1 gram monofilament is brilliant, but that needs to also be validated to be an effective early screening tool.
And a question from myself, actually, just to pick up on that point. Is there any correlation between the severity of the diabetic neuropathy in the foot and cognitive ability or cognition?
Yes, there is. And that's a very good question, because I think with neuropathy, as it advances, it causes cognitive dysfunction. And this is the work of Leanne Hunt, one of your colleagues who works in the MDT clinic. She spent 2 years researching here in Sheffield, not with myself, but with Professor Ian Wilkinson and myself. I was a little help as well. And what she's shown is that this cognitive dysfunction is there. Neuropathy is the early shoot. It's a periphery, but actually it's far more complex than we think. A lot of these patients that we have with painful neuropathy act in a very odd way. We tell them not to do things, but they do it. There is actually a dysfunction of the central nervous system. I'm sure you will have noticed this, Howard, with some of our patients here.
Yeah. Question from Linda McBurney. How reliable are nerve conduction studies? And do you have to have a certain level of change before it's picked up by nerve conduction studies?
Nerve conduction studies, that's a very good question. Nerve conduction studies are very important, but they have to be done properly. They cannot be done by somebody, or, you know, if we want them to be absolutely robust. But we can use simple nerve conduction studies in addition to our clinical examination. And they are very reliable, they're very reproducible. The neurometrics device that I showed you, DPN check, costs $1,000 US. It requires an electrode, but it gives you, and it's not very painful, and it can be done by an idiot like myself, you know, so you don't need any expert to do it. And indeed, Oliver Binshall, I don't know whether you know Oliver. Do you know him, Howard? No. He works in the foot clinic at Northern. He does them. Our podiatrist. He does them. He's an early, you know, he's actually a trainee podiatrist. So they're reliable. They can be done, but it's not ready for widespread use because it has huge funding implications, and we need to convince the government. I think what we need to do first is to have the one-stop shop to make sure everybody has foot screening.
Thank you. And time for one final question from Jill Halstead. Are the small tortuous capillary changes, I guess, that we see on the nerves also seen on nail fold capillaroscopy, as this can be readily viewed and maybe less invasive? So is there any correlation between nail fold capillary damage and that we see in
that's a very good, again, a very good, and we're getting really interesting questions that we don't get in other, so that's a brilliant. Yeah, this is actually a very good way of diagnosing peripheral neuropathy. And colleagues from Austria developed this technique first, and by looking at nail fold capillaries and the tortuosity, the oxygen saturation, but it is not an easy thing to do. It's much easier to do the DPN check in 3 minutes than to do the fluoroscopy. That's why we haven't opted to do this, but it is robust, it works, and there is a good correlation with neuropathy.
Great. Well, thanks once again, Solomon, for a fantastic talk and very clear answers to the questions. It's been a pleasure having you here today, and we're very lucky to have your expertise in Sheffield, and I very much hope the results on Wednesday go well. Thanks everyone for attending. The next talk will be at the beginning of October. And can I just remind everyone that they'll get a link to their email following tonight. And if you just fill it in and give us some feedback, then you'll get a certificate of attendance. And thanks for everyone for joining us. And thanks once again, Solomon.
Thank you.